Kumar from Hyderabad and Dr. Bharat Purohit from Hyderabad. Welcome you all to this program once again. I deem it my proud privilege to introduce Dr. T.S. Clare to today's faculty, though Dr. Clare doesn't need an introduction. The world knows him. Padma Bhushan Dr. Clare is currently working as chairman, Fortis Heart and Vascular Institute at Fortis Memorial Research Institute, Gurugram, and Fortis Hospital, Vasant Kunj, New Delhi. He has been one of the founding doctors of Escorts Heart Institute, where he spent 28 years and was its executive director for the last 12 years of his association with the hospitals. Dr. Clare is very active interventional cardiologist and has performed more than 25,000 coronary, renal, carotid, and peripheral angioplasties. He is pioneer in electrophysiology and established the first dedicated electrophysiology department in India at Fortis Escorts Heart Institute. He was the first to perform the first his bundle pacing in India in 2015. Dr. Clare has been awarded honoris causa doctorate in science by Punjab University. He has been awarded the prestigious Padma Bhushan by Government of India in the year 2005. Dr. Clare, we once again take this opportunity of welcoming you to the program and request you to take over the proceedings of the webinar as a chairperson.
Thank you very much for organizing this webinar, plus inviting me to I would just request that people who are not speaking, they should put their mics on the mute mode. Otherwise, there is disturbance. There is some disturbance in the audio coming. So could you please check that?
Dr. Clare, please unmute yourself once, please.
Yeah, I've done that. So I hope there was some disturbance coming. I hope so you are taking care of that now.
Yes, sir.
So today we, the thing is that the tricuspid valve is I would say, a relatively neglected valve, and we all concentrate on mitral valve and aortic valve, and we think if we can treat the aortic or the mitral pathology, the tricuspid valve will automatically be taken care of. One of the most common disease in the tricuspid valve is functional tricuspid regurgitation, and the assumption is for the treating surgeon as well as the cardiologist that once you take care of the mitral valve or the aortic valve, the pulmonary artery pressures will go down and the functional tricuspid regurgitation will be automatically taken care of. But that doesn't happen actually in the majority of the patients. So, and there is a clear data to show that the mortality with the functional tricuspid valve regurgitation is very significant. So far we have been treating these patients with just medication, and their quality of life as well as the longevity of life is certainly affected by the functional tricuspid regurgitation. So I'm happy that today our friends, the realistic people, have organized this symposium to how we can address the tricuspid valve. So I think I can go to directly the presentations. Am I right, Pankaj?
Yeah, sir. We request you to introduce the moderators to the audience, and then, sir, we get on with the presentations.
So we have quite a illustrious faculty and panelists. We have Dr. Ignacio Santos from Spain. We have Bharat Purohit. He is a director and HOD Cardiology Care Hospital, Hyderabad. We have Dr. Viveka. He's the Principal Director and Chief of Cath Lab at Max Saket. Dear friend of mine, Girish Nasundi, he's Director of Cardiology in Apollo Hospital, Bangalore. Dr. Prashant, he's Director, Viveka Hospital, Nagpur. Then we have Dr. Sunandan Sikdar. He's a consultant interventional cardiologist in Narayan Multi-Specialty Hospital, Kolkata. So all these people are very experienced people, and I'm sure their input is going to improve the value of this symposium. Then we have a couple of presenters, and I think we can right away start with the presentation. The first presentation is the landscape of valvular treatment, surgery versus transcatheter treatment of the heart valve by Dr. Girish. He will speak on that. Dr. Girish, please.
Thank you.
Here is his biodata. It's quite good. He's director of the cath lab at Apollo Hospital, Bangalore. He has performed a lot of angiograms, and he's an expert in femoral, radial, ulnar approach and 1600 angioplasties, both coronary and peripherally. His special expertise in performing complex coronary angioplasties, heart failure and sudden cardiac death, treatment strategies, and transcatheter procedures. He has presented a significant number of papers at various national and international conferences, and I'm sure that we are going to benefit from his presentation. Dr. Girish, please.
Thank you. Thank you, Claire, sir. It's a pleasure to share a platform with such luminaries. I have a very simpler introduction about the landscape of valvular treatment in Indian subcontinent to be put forward as a prelude to the wonderful day that is going to unfold today morning. I've been requested to speak about the the landscape of valvular disease and the scope, because there are so many young cardiologists who are on board today. So I'll start with some of the simplest of the presentation. We would realize that heart has 4 chambers. This is the superior view, where you can see the aortic, pulmonary are smaller, and then large mitral and tricuspid valves whose annuli are not as great as aortic or something to treat by transcatheter means easily. But this is the superior view to consider. And for the transcatheter therapy, what are the kinds of disease that we may encounter? One is mitral valve prolapse. Then you may have bicuspid aortic valve, and then valvular stenosis and valvular regurgitations. These are the kind of patients that we would be looking for, and diagnosis is the crucial thing. I think we must invest a lot of time to understand and relearn or reskill about the structural heart disease, because most of cardiologists have become a vascular interventionist, moving away from the structural part of it. Just going back to the history, the first open heart surgery in India was done by Nagpur Gopinath, very eminent surgeon, in 1962. And the first valve replacement from a human patient was performed in 1962 again by Surgeon Alfred Gunning from Oxford, who had been using freeze-dried valves from donated corpse. That's how the valvular therapy started in the world. When you look at the distribution and pattern of valvular heart diseases in India, valvular heart disease continues to be the leading cause of morbidity and mortality in India. We have conquered rheumatic heart disease to a large extent. There's been a progressive decline from 5.3 to 2.9 to now below 1%, 1 per 1,000 patient with rheumatic heart disease between 1970 and 2010. Progressively, there has been significant decline in rheumatic heart disease. There's an increase in the incidence of rheumatic mitral stenosis, though, with the age. Most common age group affected were between 16 to 30, and then another group between 31 to 45. This is found predominantly in the females. And the isolated aortic valve disease have been low over the years, but the bicuspid aortic valve cases are commonly seen, and there's an increase in the degenerative aortic valve disease, especially as the aging population increases in this country. The tricuspid regurgitation, I think today's discussion, I think very, very neglected part of the valvular disease and thought to be very innocuous where it is not so. And you feel so helpless when one has this problem. Tricuspid regurgitation has been seen very commonly. An earlier concept of treat the left heart to resolve the right heart issue is no more valid in the current therapeutic arena. Isolated tricuspid regurgitation cases constitute about 10% of the total tricuspid disease. And pulmonary valve cases are associated with usually ventricular septal defect or in association with some other cardiac disease. Multivalvular disease is seen in significant number of patients. The most common pattern of multivalvular lesion has been mitral stenosis and mitral regurgitation. Mitral, that is not multivalvular, single valve, but you could have both the disease, stenosis and regurgitation together. Or multivalve is usually mitral stenosis and regurgitation of stenosis. I request the the organizers to mute everybody except the speaker. Thank you. The other multivalvular disease also has been both regurgitant lesions, mitral regurgitation, aortic regurgitation. Also, oftentimes we see tricuspid regurgitation, which is either secondary or in few cases a primary disease. When you look at the valve surgery in India, I think Indian surgeons have been fantastic, one of the finest surgeons in the world. The first procedure was a valvotomy for the mitral valve that was achieved with the surgeon's hand. And then came the types of valve replacements. Initially, it was open heart surgery. And then today it has mostly become minimally invasive cardiac valve surgery. My colleague surgeon, Dr. Satiki, he does double valve through minimally invasive, 2 small incisions. And transcatheter heart valve replacement has been the newer modality which has come, and it has changed the the horizon of treatment that is available today to many patients who are just condemned on some lifestyle and medications. When you look at the heart valve procedures, the heart valves, when they're diseased, either because of stenosis or severe regurgitations, the replacement was one option. We know that actually destroys the normal structure, and it's not a long-lasting procedure. When you look at by position, the heart valve replacements can be in the aortic, mitral, and there are cases of tricuspid regurgitations and pulmonary valves as well. It's not been only to aortic and mitral. When you look at by technique, it could be either surgical or it could be transcatheter. Mechanical, when you look at the by technique, the surgical, they were using mechanical heart valves, especially in young rheumatic heart disease situations. But now it has moved to a tissue valves to a large extent, even in this country. When you look at the repair, that is the one which is actually longer lasting and more physiological. The heart valve repairs can be done through surgery or also through catheter, like transcatheter mitral valve repairs that can be performed. So we are in the zone of repairing than replacing if it can be achieved. Coming to the Indian scenario, which is relevant for today's discussion, India had more than 1 crore patients above the age of 80 years in 2013. The current population of India is 1.3 billion. If you take it, as per the recent demographic data, about 6% of this population are above the age of 65 years. That accounts for about 70 million. So 7 crore. On extrapolating the Western data to this population size, there are about 3 lakh patients with aortic stenosis eligible for transcatheter aortic valve replacements. 3 lakh patients. This number is more than the estimates from the Europe or North America together. So transcatheter heart valve, it's a promising domain that we'll be discussing and looking at its evolution and strength. A minimally invasive procedure to replace heart valve is superior for patients with an intermediate risk or high risk of complications associated with open heart surgery. More than 1/3 of the patients with heart valve disease are unable to undergo a surgical procedure, either because of comorbidities or psychological cause. Many fear putting themselves under a knife. Management of such patients has dramatically changed with the advent of the percutaneous therapy, and the transcatheter heart valve approach is promising in all valves such as aortic, mitral, tricuspid, and even pulmonary, and reducing associated risk of the procedure. Advent of advanced technologies are enabling better treatment in the domains which were not treatable earlier for many reasons. When you look at the transcatheter heart valve in India, the first clinical expertise with transcatheter heart valve in India was back in 2011 in an 80 years old female patient with severe aortic stenosis. That was a Medtronic core valve 26 deployed through transfemoral route. Since then, currently transcatheter valves are being done in about 60 centers across India, out of which about 11 centers handle a large load of transcatheter valve therapy. That means there's a huge opportunity. However, there is a need for standardization of protocols, upgradation of the operator skill across the country. Heart team approach is another very, very crucial thing that brings 2-3 specialties, anesthesia, cardiac surgeon, cardiologist, and a physician together to beef up a decision-making capability across the country. Now, when we look at the total valve cases in India, still 76% of the cases are mechanical valves and only about 23% are biological, and transcatheter valves are at abysmal 1%. That has the greatest potential to grow. Transcatheter valve market, when you look at it, market by product, you can see then transcatheter aortic valve replacement, transcatheter mitral valve repair and replacement systems, and transcatheter pulmonary valve replacement systems. And when you look at the surgical approach, the current scope available, transfemoral, transapical, and other hybrid approaches. And when you look at by application, aortic valvular heart disease, either you could have for the aortic valve stenosis or for aortic valve regurgitation, mitral valve stenosis or mitral valve regurgitation, pulmonary valve heart disease, and finally, tricuspid valve disease. When you look at the end use, it could just be cath labs of the hospitals. When you look at the dynamics of population which benefits from these therapies, locals have been contributing to the maximum, that's 93%, and the international patients, medical tourism has contributed only 7%. But what are the primary challenges to transcatheter heart valves in our country? One is we have not set up proper protocol. It needs standardization. And greatest hurdle has been, upgradation of skill by the very skilled cardiologist population and cardiac surgeons population in this country, and willingness to challenge themselves to upskill. And then non-availability of heart team approach. I think, people tend to make independent decisions, either cardiac surgeon or a cardiologist, even in a sick patient. I think developing a heart team approach greatly enhances better outcomes, and mutual coordination is very essential to run this therapy, that is transcatheter heart valve. And also there is a reluctance from physician and patients to accept this novel therapy, and also not being aware of it. Delayed approvals by the regulatory is adding to the delayed adoption of the therapy in the country, and non-availability of transcatheter heart valve treatment option in medical insurance. That's another big hurdle. Although people pay their insurance, this is not yet completely reimbursable. I think all the companies need to talk to the insurance, all the manufacturers need to talk to all the insurance companies. The road ahead, surgery versus transcatheter heart valve. Surgery remains gold standard. Remember this, it's still a gold standard. Prevalence of rheumatic heart disease will keep creating the space for mechanical valve prosthesis, especially in young people. Low cost of surgery and no learning curve is a great challenge. Since surgery has been so low cost in this country, transcatheter appears tremendously expensive. Availability of an alternative procedure called MICAS has again made, patients, surgical mitral valve, aortic valve patients get discharged on the third day with this minimally invasive cardiac surgeons. So we need to be really good at what we are doing as interventionists to compete against that. Transcatheter heart valve procedure is picking up in India as better long-term clinical results are being understood globally. There are always inoperable patients who cannot undergo surgery for valve disease, which are the candidates primarily for transcatheter heart valve. Lowering of incidence of rheumatic heart disease due to changing lifestyle is also leading to more degenerative or congenital diseases which are amenable to transcatheter. Rise in geriatric patient population who will accept biological valves with least anticoagulation. Cost of devices are also getting lower. That makes it the therapy available for larger population. An increase in patients from medical tourism also adds another segment. When you look at the future of transcatheter procedures, transcatheter aortic valve replacement market is valued at about $2,745 million was in 2018 and expected to reach almost 3 times, 6,225 million by 2025. I mean, that is the growth forecast. Rise in the geriatric population, along with increasing case of heart disease, is driving the global transcatheter aortic valve replacement market at this point. So this is where India would also be heading. So hence, it's very, very important that we discuss, increase the awareness, and reskill ourselves and regroup as a heart team to be a better transcatheter heart valve therapy group. While surgical option of treating valvular lesions continues to be the best option, there's an increased inclination towards the adoption of transcatheter heart valves. Advancement in technology is contributing to the ease of procedure and predictable outcomes. Wider inclusion criteria, low risk, improved prognosis, earlier hospital discharge is the icing on the cake through this THV therapy. And this is where I conclude and I'll leave it to the next presenters. Thank you.
Thank you, Dr. Girish. So, Dr. Clay, we have next.
I'm sorry, I'm not able to hear.
Yeah. Sir, am I audible? Dr. Clare, you are on mute. Request Dr. Clare, Dr. Girish, please unmute. Dr. Clare, could you please unmute, sir? Okay, so sir, we would next go to the presentation of.
Okay, am I audible?
Yes, sir.
Yeah, sorry, there was some little glitch in the computer. So I think Dr. Girish has covered the overall landscape of the valve therapies and the valve problem in India. Well, I think apart from the factors which he has counted, that why we are not able to adopt the technology is that the cost of the new technology is also prohibitive for many of our patients. But I am very confident that the Indian cardiologists are skilled. Their learning is not a problem with them. So I guess that this technology, all the transcatheter valve therapies is going to become more and more important in our country. Well, I think next we have, so when we talk about the tricuspid valve, transcatheter therapies, basically we are directing at three kind of directions. Either we repair the ring, or we improve the coaptation by some technology like mitra clip, or we have the valve implantation, tricuspid valve implantation, or we put cable, valve. So now one of the technology is the trick valve, and for that we have very experienced speaker, Dr. Ignacio Santos from Spain, and he is the director of the CTO program and non-coronary interventional program. He does everything: TIVA, mitra clip, AST, PFO closure, and the septal ablation. He is the first operator research coordinator in invasive cardiology, and he has various publications in national and international journals. He is a principal investigator in many studies. I think we are very excited, Dr. Santos, to
I'm
listen
not
to
getting
you.
a connection. Yeah, send me the link, please.
So I think without wasting time, I will request Dr. Santos to present his paper.
Thank you so much for the kind invitation once again to this meeting. For me, it's very exciting to share my experience with you, because it was very interesting, the presentation from Dr. Navasundi, since I can see that there is a target population for this kind of technologies that is very large in India. And I think it's very important to discuss all the aspects of these therapies. So one of the problems that we face is that when surgery was started, and this was mentioned in the prior presentation, it was unclear what to do with tricuspid regurgitation. Actually, initially it was thought that just correcting the left side valvular disease was enough, no need to touch the tricuspid regurgitation. But with the years, we have seen that the tricuspid regurgitation can mark the prognosis of these patients. In Europe, we have a much older population than in India. In Spain, currently, the mean life expectancy is 83.4 years of age, which means that we have a huge target population with degenerative valvular disease, while rheumatic disease is a much smaller proportion. We are treating mainly percutaneously aortic stenosis. Now, percutaneous treatment has become the first therapy for aortic stenosis above surgery. But the number of patients, the proportion of patients presenting mitral regurgitation and tricuspid regurgitation, as you can see, is higher than those with aortic stenosis. So there will be a shift in the therapies that we're using, mainly percutaneously, in the following years in this setting. In 2019, we review our experience and we review all the echocardiographies that we have performed, and we found that 2.7% of these patients undergoing echo in our department presented severe tricuspid regurgitation, severe, torrential, or massive tricuspid regurgitation. In general, these patients presented several comorbidities. 13.5% had died 1 year after, and more than one third of them had been readmitted in the follow-up. This means that these patients are really sick and are requiring a lot of resources from the health system. Only a total of 6 patients received treatment. 3 of them underwent surgery, and 3 of them underwent percutaneous treatment in this period, in 2019, in our institution. This means that we are not giving solution to most of these patients. Of course, a proportion of them are secondary to pulmonary disease or other problems, but the huge majority of these problems of this tricuspid regurgitation are secondary to left heart surgery, which means that we really need to find a new approach for this problem. We know that not only severe, but also moderate tricuspid regurgitation deteriorates the prognosis of these patients. And this is irrespective of the pulmonary pressure and is irrespective of the left heart function. And we also know that in the best centers for heart surgery, there is a high mortality, higher than for any other isolated surgical valve. Around 9% in the best centers is the mortality immediately postoperative, and even higher if we follow up the patients at 30 days and 1 year. We don't have the ideal solution yet, and this is why there is such a wide range of percutaneous technologies for these patients. This is a landmark study by Taramaso, where they describe for all these pooled technologies a 30-day mortality of 3.6%, which is quite good, but the persistent 1-year mortality of 23% with percutaneous alternative, which means that we are not still at the ideal scenario. And why is that? For me, the main reason for that is that we still don't know when we still can treat these patients. Most of patients are discovered in this time of the evolution of their disease, which means that we are around the point of no return. This point of no return is marked by the tear severity, annular size, mainly the degree of dysfunction of the right ventricle, but also by the accompanying comorbidities in these patients. If a patient has very severe right ventricular dysfunction determined by echo and by right heart catheterization, this patient will not benefit from any alternative, neither percutaneous nor surgical. Then we can distinguish primary tricuspid regurgitation, that I understand is a huge problem in India for your patients. And in this context, we can use different alternatives as well as for secondary. Orthotopic valves, as I will mention later, probably are not there yet. And mainly this is because the introducer is very large. We need to go through the atrium, which is very aggressive for these very sick patients. Mitral clip, or now TricValve, is not a very good option for rheumatic patients. Cardioband can be also an alternative for functional TR, but not for rheumatic one. And CAVI alternatives, those implanted in the cavas, might be a very good alternative. But again, in the algorithms, it has been always positioned at a very advanced stage of the disease. Yeah, we need to remember that this should be used in mild to moderate right ventricular dysfunction, not end stage heart failure, not very dysfunctional right ventricle, because then the prognosis is not going to improve, or even we can promote a further deterioration of the patients. What do we know about the current most used options? Well, TricValve has several data now. The aim in the main studies has been just not very ambitious, just to decrease 1 grade the tricuspid regurgitation, and this was achieved in 86% of the patients. And the main problem from my point of view is that still there is a too high rate of single leaflet detachment once the clip has been deployed. Navigate is the most known valve for tricuspid regurgitation. We have some experience in Spain, but as I mentioned, this is a transatrial implantation, so it's not fully percutaneous, which means that there is an increased morbidity of our patients. And indeed, in the results published in JACC Intervention, and as we discussed in this letter in the same journal, the 30-day mortality was still high, 12.5%. We know that these are unoperable patients, very high-risk patients, but also very interesting is that once the valve is implanted, a right ventricular dysfunction was unmasked in many patients because the right ventricle was moving, but once we remove the tricuspid regurgitation, this is not moving so much. So more than half of the patients require inotropic support. This means that selection of patients is still poor for this technology, and not many patients are candidates to this technology because they might further deteriorate afterwards. Cardioband is a very interesting concept, very similar to the surgical concept, with initial success rate very high as reported. The problem of this technology probably is the complexity from the structural point of view. Imaging is crucial in these patients, transesophageal echo with 3D reconstruction images, and the mortality persists still high at 1 year of follow-up with the technology. So CAVI appears as an alternative that is less invasive, much less complex from the technical point of view, also less physiological, because what it induces is a ventricularization of the right atrium. So it is not going to correct the tricuspid regurgitation, but all the secondary symptoms due to congestion in the venous system. And through reducing this congestion, the aim is to reduce also the volumes of the right chambers. We will see this later. What do we know? These are the manuscripts regarding CAVI alternatives that have been published in 2020, before 2020. And we find a procedural success that was very high in the pooled analysis, 92%, but there was a high need of conversion to open surgery. And this was mainly due to embolization. Why this occurred? Because we were using valves that were not dedicated to the CAVA, that were dedicated to other setting and were used in the CAVAs. And this was published also a few days ago in Neurointervention, the experience with SAPIEN 3, and this study was stopped because there were embolizations. But now we have some alternatives that are dedicated to the CAVI setting. One of them is Tricento. It's a stent from the superior to the inferior vena cava. This is a case from our center. And as you can see, there is this movement of the stent that has caused that in the initial experience, there were some fractures of the stent with some leakage appearing, which is a problem for the efficacy of the technology. The stent went out of the market and now is back to the market. It has been reinforced. And we have to see again how this works. But the most used alternative in our setting is TricValve, which are two different valves, one implanted in the superior vena cava and the other in the inferior vena cava. Imaging is crucial, and probably the most important imaging for planning and performing these procedures is computed tomography. This is a reconstruction with simulation in one real patient. And CT allows us to decide how high we are going to implant the SVC valve, how low we are going to implant the IVC device, and to have more information. This is a very quick case. Again, CT is very important. It's a patient with left heart valves, and we can see here then. We see here where we have to measure to decide the sizing of the devices and how we want to position. So we move to the case. It's a patient with a failing, it's a patient with a failing annuloplasty. You can see it's a 27 French delivery system. It's a bit accelerated, the video. It's a Charles Chaplin film. And we can see that it's quite simple. We just advance the upper valve, which is nicely implanted. We remove the first delivery system. We can see by TE how it's working. Now we do angio in the inferior vena cava. We see a large ostium of the hepatic veins, which is often very dilated. The distance to the hepatic veins is not a problem with this device, which was with Tricento device if it was too close. And now we proceed to open the valve, which is sealed with pericardium only in the upper 2 centimeters. So this is our landing zone. And here we can see by TE how we measure how deep we are in the atrium. This is very important. Here, imaging is crucial, can be transthoracic or transesophageal echo, but we need to be no more than 1 centimeter into the atrium to avoid leakage. So the combination of both angio and echography are crucial during the implantation. And the other crucial aspect is a very slow deployment. This is not TAVI. Patients are very stable during the deployment. So we have to take our time. And this is the final angio with no backflow to none of the hepatic veins and an inhibition of the V wave in the atrium and inferior vena cava. Here we see the leaflets working perfectly in this case. So, as I mentioned, the CT computed tomography is crucial. We have performed all the analysis of the baseline and post-implantation computed tomographies. This is taking in consideration the measurements here in red. You can see the different shapes of the superior vena cava. Some of the superior vena cavas are very short and very tapered, and these are the high-risk cases for embolization. Some others, and some others are longer and more parallel. In these cases, it's easier implantation. So the risk ones are these kind of morphologies. Okay. Also, we have used our 3D printing lab for some challenging cases, like this one. Please, can you all silence the micros because it's really disturbing. So in this case, the problem was that the vein was very short and very tapered. And we have to protrude quite a lot into the atrium. So we did it in the 3D printed model to make sure that we could implant in the patient. And here is the image from the actual patient next to the 3D printed model. And you can see that we really reproduce the implantation. We have reviewed this topic in some cadaveric models. And as you can see, the landmark is the innominate vein when it arrives to the superior vena cava, because the upper part of the device is not covered with pericardium. This innominate vein should arrive here. If we implant higher than that, then we will cover the innominate vein. On the contrary, we usually cover the ostium of the azygos vein entering the posterior wall of the superior vena cava, and this is not a clinical problem, at least to the date. And regarding the inferior vena cava, reviewing all the CTs, we have identified different morphologies of the inferior vena cava, and the two upper ones, the pizza tower shaped and the C-shaped, we have an angulation when entering the atrium, are those with higher risk of leakage or embolization, because the valve tends to adapt to the morphology of the vein once released, which might create a leak if this goes up too much. Okay. Also, we can identify some innervation. This is the solar plexus around the inferior vena cava, and because of that, the distension of that, patients might have a pain in the right shoulder once the valve is implanted that occurs in about 1/3 of the patients, and it relapses after 24 to 48 hours. But it's important to understand this mechanism. I'm going to get through this. There are some lines in the presentation that someone drew. I don't know if you can remove this from the organization. This is the current experience with the TricValve system. There was a special access program for the first 10 months with 100% procedural success. And I'm going to describe the early feasibility trial and the CE mark trial. The valve just received a few weeks ago the CE mark approval for commercial use in Europe. So if we look at the clinical experience until now, we can see that very interestingly, there was a proportion of patients that have a prior pacemaker. This is one of the very few alternatives for patients that have a functioning pacemaker. We can implant the valves without any problem in the leads. The leads will continue working properly. And patients were quite sick, and most of them have prior left heart surgery. There was no in-hospital mortality, no stroke. There was only one conversion to surgery in the Tricus study because of an embolization of one valve. No cases in the Tricus Euro study that we performed in Spain and Austria. There was one late migration of one device. You can see this was one of those patients with very short superior vena cava, very tapered. And after 24 hours, we found the superior vena cava valve has go down to the atrium, but this was left like that. And very importantly, in the last part of experience, we decided to stop doing orotracheal intubation and to stop using transesophageal echo, because since these are sick patients, all of them with anticoagulation, we want to avoid all the aggressions, all unnecessary aggression to the patient. And with this strategy, you can perform the procedure very nicely and discharge the patient in 24 hours. We have detected a significant improvement in quality of life in terms of NIHA class, 6-minute walking test, and questionnaires of quality of life. There were no changes in the follow-up in TAPSE, right atrium area, or pulmonary pressure, or left ventricular ejection fraction. And very importantly, this is a little bit counterintuitive. When we implant these valves, there is not a dilation of the right chambers, but a reduction in the size of this of the right chambers because of the reduction of volume overload that these patients are experiencing. This is a control CT at 3-month follow-up of one of our patients, where you can see the very appropriate remodeling of the patients. And in particular, there was a detection of a significant decrease in the ratio of the RV-LV diameters, which is a well-known prognostic factor in other diseases. Also, very importantly, in 2 cases in the follow-up, thrombi were detected attached to the stent, but not in the leaflets. You can see here the functioning of the leaflets was adequate, and probably these cases occurred because of low-range anticoagulation. And from the point of view of the hemodynamics, there was a significant decrease in the Doppler backflow to the hepatic veins and a significant decrease in the V wave in the inferior vena cava. No changes in other relevant biochemical parameters. So there were no device-related mortality cases, only 1 procedural-related death. There were several events, 1 hematoma at the access site, 6 cases of respiratory infection, and this is why we are now avoiding orotracheal intubation. In the follow-up, 2 admissions due to heart failure and 1 death non-related to the technique itself. So my conclusion is that TricValve is a new, promising, and less invasive concept for tricuspid regurgitation. We have seen a successful and uneventful initial experience. Patients have experienced improvement in functional status, quality of life, and hemodynamics. We don't know yet in the life expectancy, but if we can confirm this in a larger number of patients and at longer follow-up, this might actually open a new avenue for the treatment of tricuspid regurgitation. Thank you very much.
Thank you, Dr. Santos, for a very, very exciting presentation. The patient who had to go to surgery, may I know what was the reason for that? What happened?
Yeah, this was during the early feasibility trial. In that study in Lithuania, there were involved 9 patients, and they have 1 patient with embolization of the superior vena cava prosthesis. So the patient was, of course, stable, but there is a valve in the atrium, and they decided to undergo surgery to remove the valve and to implant an annulus, a surgical annulus in the tricuspid valve, and the patient did well afterwards.
Now, one thing is, I want to ask you that when you have the, you measure the, on CT diameter of the superior vena cava and inferior vena cava, what percentage you oversize the valves?
So these are self-expanding valves. And like in TAVI, the degree of oversizing has to be a little bit excessive, so to say. So we have to be oversizing between 10 and 20% according to the diameter. But this is very variable because the superior vena cava can be like this, can be like this. So it depends on which diameter you take as reference.
Right. And what is your protocol for anticoagulation after the valve implantation?
So to the date, all the patients that have been treated with this technology had a prior indication for anticoagulation, meaning atrial fibrillation or mechanical prosthesis. So anti-vitamin K or vitamin K inhibitors are probably the best option by now for these patients. Although we have had some of them with new oral anticoagulants with good outcomes as well.
Dr. Santos, I am sure you must be knowing many other people who have used or who are using this TricValve. Do you know or a rough estimate that how many total these valves have been done in the world?
As I've been informed, more than 100 now worldwide with this technology. Yeah, worldwide. And with the alternative technology, Tricento, which is also a CAVI option, I think there are about 30 cases worldwide.
All right. So as far as I understand, that your pre-operative assessment is much more important, but the procedure itself is pretty easy. Am I right?
Yeah, you are right. Just taking into consideration a few challenging considerations as taper superior vena cava, taper and short, or those patients that have an angulation of the inferior vena cava when entering the atrium. These are the higher risk cases in terms of risk of leak or embolization. But other than that, the procedure is quite simple.
So if the patient after this valve implantation needs a pacemaker or a device, intracardiac device like ICD or a CRT, so what are the challenges you will face?
So the challenge, we have reviewed all these patients and we have seen that the lead is working properly. So
no, I'm asking if they need in future,
okay.
What will happen then?
Okay, so you have two options. You can place the pacemaker normally through the superior vena cava valve, although you risk that the superior vena cava valve might dysfunction, but most of the symptoms are corrected by the inferior vena cava one. And the other option is to implant a Micra, a leadless pacemaker, which is probably the best option for these patients.
Right. Did any of your patients required a pacemaker or an intracardiac device after this valve?
There has been not in my center, but in another institution, one patient required a pacemaker and a Micra was implanted. One of the good things of this technology is that they do not preclude from future procedures, transeptal procedures. If you need to do a left atrial appendage closure or a mitral valvuloplasty or something like that, you still can work normally.
Right. So I think we thank Dr. Santosa. I think we'll have more discussion at the end of the session. And now I would like to invite Dr. Viveka to tell us about Indian scenario in valve therapies. Dr. Viveka, as I told you before, he is the principal director at the Max Saket, New Delhi, and he has wide experience in interventional cardiology and does everything practically, and he is written a lot of papers, and he's a national and international proctor for TAVI, ROTA, IVUS, OCT, and things of that nature. So, Dr. Viveka, let's listen to you as far as the Indian experience is concerned.
Good morning, friends, and a special thanks to Dr. Claire for kind introduction. I think it's been very fascinating journey that from this surgery we are moving to the minimally invasive or minimalistic approach as far as the treatment of the valves are concerned, and we know that right from the aortic valve space, and Dr. Santosh has clearly shown that in tricuspid regurgitation also the newer system, especially the TricValve, is going to help a lot of our patients. So I'll briefly touch upon what we are going to, what we are doing right now, what is the Indian data. And so if you look at the Indian experience, the whole gamut of doing percutaneous interventions for the valve is that, what Dr. Kaushik has said, that anything a cardiac surgeon can do, an interventional cardiologist can also do as well, or even better percutaneously. So there has been a paradigm shift, and right from, so we had balloon valvuloplasty, especially the mitral intervention, is very, very old and well-established procedure in our country. So there has been, severe mitral stenosis, which is very common in our country, is effectively being dealt. So we have ventured into, so hardly any mitral valve stenosis which is suitable for ballooning goes for surgery. Now there is no CMV done, all balloon mitral valvotomy is done. And if you look at the guideline indications also, that all symptomatic moderately severe mitral stenosis would go for balloon mitral valvotomy or ETMC. For mitral regurgitation also, this is, all the catheter-based options are going on, but as of now, the established procedure is the transcatheter mitral repair in appropriate cases. The mitral clip has taken the space, and many patients have been done globally, and now it is available in our country also. Few centers and few cases have been done, but the problem in the mitral thing is that in mitral space, that because of the complex anatomy, the percutaneous mitral valve replacement is not has taken that kind of leap, but now the newer data are showing that this is going to work. Aortic space also, we have self-expanding and balloon expanding valve, and in this also, this is now very well established, as shown by Dr. Girish also, that there are a lot of patients who are in our country also going for valve. So, but still, as Dr. Santosh has said, that there are many patients who have got severe valvular disease of all the, one or the other out of the 4 valve in the heart. But because of the prohibitively high surgical risk, many of them, they are not able to go for surgery, and this data is only for the aortic space valve. So scope for TAVI and similarly for the other valve is really very high. So we need to, not only for the TAVI, we have for the other valvular space also, we have to have, heart team and suitable patients. And this is the comparison between the balloon expandable and the, self-expanding valve. The indications of the TAVI and the things have come down now. Even it is a class 1 indication for low risk patients also. This is, few cases which we have done for the valve in valve also, for the mitral space and the aortic space also. So the valve in valve for mitral space is, relatively easier. For severe aortic regurgitation also, now we have got percutaneous answer. And, these are the various guidelines from AHA, ACC for valve implantation. So if you look at the, Indian scenarios, because any patient who is eligible for tissue valve is eligible for percutaneous treatment as well. So if you look at the current status here in India, the open heart surgery valvular intervention is the maximum. And as Dr. Girish has also said that our surgical colleagues have ventured into minimally invasive cardiac valve replacement surgeries, and they have been doing, we had at our center also, many of these standalone tricuspid valve could not afford the, TricValve and on, has undergone surgery because their life was miserable because of the severe torrential, tricuspid regurgitation. But once the availability of this transcatheter valve system is there, then many people are going for that. This is the data of total valve cases in India. You can see, the mechanical valve is the bigger space because our patients are relatively younger. So understandably for the longevity, the mechanical valves are more commonly being used, but the more and more, older patients, and now we have got access to more durable tissue valves. So probably the uses will be in much more younger patient. And this is the, algorithm how to proceed in this valve. India has more than 10 million patients above the age of 80, and out of population, 1.3 million, above 6% are above the age of 65 years, and that means around 70 million. So extrapolation of the above data gives an inference in India. There are about 3 lakh people who had only aortic stenosis problem and are eligible for transcatheter implantation. So the valvular disease and treatment wise, now, as I said, that the gold standard is surgery, but now with the heart team, we are seeing the cooperation from the surgeons also for getting the percutaneous treatment in high risk cases. So, as it has been shown that, the journey for transcutaneous valve started in India from 2011, and it's been on the upward swing, and many centers have, including ours, have ventured into it. And it's very exciting that we would have very soon, apart from the aortic and mitral space, the tricuspid valve and pulmonary valve, which was started with Melody, and these valves can be implanted in this situation. So transcatheter valve in India is, today the procedures are done mainly, as it has been shown that, around 15 to 18 centers are doing more volume than the other centers. But the challenges are the, patients of reluctance. The cost is also a big factor because all these percutaneous valves are very costly. The regulatory approvals and all is issue, and prevalence of rheumatic heart disease, because all these data are from non-rheumatic valve. But in India, still, though the rheumatic heart disease is on decline, but a lot of patients are there who have got rheumatic valve disease alone. So we need to, overcome the challenges, which is the financial, insurance, and the training institutions. These things would really make things easier and take the, into new direction. So moving ahead with the surgery versus, transcutaneous heart valves, prevalence of rheumatic heart disease keep creating a space for mechanical valve prosthesis, especially in younger, a lot of the patients. We need to have, with the tissue valve, the longevity is still a question, which is implanted percutaneously. The case selection is very, very important. And, rise in geriatric population will accept biological valve with the percutaneous technique more often than not, once the cost is in the treatment. And to conclude, I would say that though the surgical approach remains gold standard for valvular disease, but that transcutaneous heart valve approach is catching up fast. There is a low risk involvement, so we can offer those gaps. There was a bridge which had been filled with the percutaneous valves. They ensures low surgical convalescence. The patients can be discharged within 48 hours and has got wider inclusion criteria, now has more long-term clinical results, and there is a reduction in trend and cost of the hardwares also. So thank you very much for your kind attention, and if there is any question, I'll be more than happy to answer that. Over to Dr. Claire.
Thank you, Dr. Viveka, for overall view of the valve therapies in India. Of course, our population is growing, and I'm sure that this 70 million numbers will become more and more in the next couple of years. So I think we have to gear up for the cardiologists in the country, need to gear up for transcatheter valve therapies. One of the biggest challenges remains the cost, and I think some insurance and all those things we have to take care of that. So let's move to the next topic now. The next topic is the peculiar anatomy of the tricuspid valve, and what do we mean? What is the importance of tricuspid regurgitation? To cover this topic, we have Dr. There is some kind of noise coming. Can you people, guys, look into that? So Dr. Bharat is a director and a chief of cardiology at CARE Hospital, Hyderabad, High Tech City. And he has the credit of initiating TAVR program in Andhra Pradesh. He was the first to implant leadless pacemaker in that area. After the commercial ability, he had been part of the team that implanted the first bioobservable stent, vast experience in performing complex angioplasty, CTOs, retrograde, post-bypass surgery, and all kind of difficult renal carotid procedures. So he has the credit of delivering lectures and presenting cases in various national and international conferences and a lot of publications. So let's listen. Bharat would be very happy to listen to you about the tricuspid valve peculiarities. Thank you.
Thanks, Dr. Claire, for this nice introduction. And it's been a privilege to be a part of this discussion where more than 300 people are already joined. It shows the enthusiasm and the interest among all the cardiologists in India in transcatheter valve therapies, and especially tricuspid valve. And as Dr. Santos has earlier quoted Dr. Brunwald, that it's not important, it's almost like a vestigial, and that is what we have learned from our surgical colleagues also who do congenital heart disease, doing Glenn and Fontaine. They were just simply bypassing the entire right system, thinking that it has got no value. So my job is today to basically decide on what is the unique nature of the tricuspid valve and what is the importance of treating a patient who has got a significant TR. Now, this is how a tricuspid valve looks, and we open it from the right ventricular side. And if you see here, this is the tricuspid valve system, and these are the chordates, and these are the papillary muscles which are there. This is the inlet portion of the heart, and this is the outlet portion of the conal part. And then this is the pulmonary artery. This is the right atrium, and this is the appendage here. So this is how anatomically the right side chamber actually looks. So the tricuspid valve complex, actually, it's just like a mitral complex. It's a complex which consists of the annulus, the 3 leaflets, the supporting chordates, the papillary muscles, and the part of right ventricular and right atrium. Any anomaly in any of these systems can give rise to a patient developing tricuspid regurgitation. So that is where the importance of understanding is very important. The tricuspid valve actually is not a homogeneous, or it's not a oval shaped structure. It's more like a saddle shape. You can see here, this is how it looks, and this is how actually it looks. This is the anterior leaflet, and there is a posterior leaflet, and then you have a septal leaflet. Now, and then they are subdivided by some commissural cups also, and the number of cups can vary from 2 to 8. And then you have these leaflets which are attaching to this, the papillary muscles which are attaching to this leaflets. So this is how the saddle shape looks. If you look at the end-on view, and this is how the saddle shape looks actually. So this is the anterior and this is the posterior. So you got this green one, which is the septal leaflet. The red one is the anterior leaflet, and the blue one here is the posterior leaflet. And these are the attachment: the anteroseptal, midseptal, the posterior and the anteroposterior. So this is again a diagrammatic representation of the entire tricuspid valve system, where you have the anterior leaflet, the posterior leaflet, and the septal leaflet, and then you have these three papillary muscles, the septal papillary muscles. The septal papillary muscle is actually the smallest one, and it is more medially attached to the ventricular septum. The anterior papillary muscle is the largest, and it attaches to the anterior portion of the anterior wall. And this is the posterior papillary muscle, which is bifid or trifid, and it arises from the inferior wall. So this is how in the end-on view it looks. The anterior papillary muscle is anterior, and these are the posterior, which are in the posterior part. And this is the septum, interventricular septal, and this is where the septal papillary muscles are attached. And there are around 25 cordae which go from this papillary muscle, and they connect and they tether this various wall cups. So these papillary muscles, they come out in a fan shape, and if you have any dysfunction either due to rupture or due to the ischemia and or due to the annular dilatation, and then you get this or the RV dilatation or the annular dilatation, you can get a patient developing significant tricuspid regurgitation. So this is how, this was the diagrammatic representation, and this is how it truly appears. You open up the eye. So this is the most anterior part. When you look at from the chest side toward the sternum, this is the anterior papillary muscle, and these are the cordae. And just behind this, you can see the posterior papillary muscles, and they go in the back side. And then on the medial side, which is the interventricular septal, you have this posterior papillary, this is the septal papillary muscles, which are connected here. And these are the fan-shaped things, are the cordae. So you might have seen the patient is developing right coronary occlusion, circumflex occlusion, or in the LAD occlusion. When the papillary muscle blood supply goes down, then you can have either ischemia or an infarct, or if there is an endocarditis, or if there is any trauma, or because of something, if these cordae or the papillary muscles get dysfunctional, you can get a TR, or if the RV gets dilated, or if the atrium gets dilated, then the annulus gets dilated, and that gives rise to development of TR again. So this is a normal. Generally, out of the three papillary, the three septums, the anterior, posterior, and the septal leaflet, the septal leaflet moves very less. Is the basically the anterior posterior leaflet which moves, and then they behave almost like a bicuspid valve, and that is where they coapt and then give rise to the closure of the valve. It doesn't close like a oval shape, or it doesn't close like a circular shape. So when these two, when there is annular dilatation, you can see the coaptation doesn't happen properly, and then you have a TR. But this is a normal pathology, and if there's a cordae rupture, then one side it gets elongated, and then you can have lack of coaptation, and then patient can develop a TR in this subject. And when you think of treating this patient, the reason why many of these therapies did not work out was because of the association of so many important structures which are in and around the tricuspid valve. But the three most important thing, the first is the non-coronary sinus of the valsalva is adjacent to the anteroseptal commissure. So any transcatheter valve therapy, it requires anchoring in this region, and that is where it risks the perforation of the aorta. So that is where the problem comes if you are going for a transcatheter therapy. The second is the AV node is very close by. So if you have any ring or any attachment which is trying to close it, and you cause any damage, and then you can have a complete heart block. And third, the right coronary artery is also very close by. So that can also give rise to ischemia. Initially, the RCA may be a little far off, but ultimately it starts getting close to it. So these are the important anatomical structures which has to be kept in consideration before we think of adopting any specific surgical or a transcatheter therapy. That is how they have to be designed so that you don't catch any damage to these surrounding structures. Now, these are the gross anatomy, but as a cardiologist, we are cardiologists, we are not surgeons, that we look into the gross anatomy. How does this wall look when we look at it? I'll just give you a brief, because it is very difficult to see all the three leaflets in one view. So we must understand in which view we are seeing which leaflet. So if you are going into the inflow view, and we know that when you put a cursor in the parasternal and go into the inflow view where you're looking towards the right hip, then if you are able to open up the coronary sinus or the interventricular septal, then the two structures, to the two leaflets which you are seeing, This is the blue one. The blue one is the anterior leaflet, and this yellow one is actually the septal leaflet, and the green one is the posterior leaflet. So if you are in an inflow view and you have opened up the coronary sinus, or if you are seeing the interventricular septal, then probably the two leaflets which you are seeing are the anterior and the septal. Now, if you are only seeing, if you don't see these two things, then the two leaflets which you are seeing are the anterior and the posterior. Now, if you are in the apical four-chamber view, this is the, and you have opened up the aorta, that means you are going a little more anteriorly. What you will see is the anterior and the septal. And if you go posteriorly, when you see the coronary sinus, and this is where you can see the posterior leaflets in this patient. So if you are in the short axis view again, you can, if you see only the one leaflet, if you are seeing in the short axis view, then it is probably the anterior leaflet. And if you are seeing two leaflets in the short axis view, then the two leaflets which you are seeing are the anterior and the posterior leaflets. And as I have already told you, if you are going into the inlet portion and if you are opening up the coronary sinus or the IVS, then the two leaflets are the anterior and the septal leaflets in this patient. So this is how in a 2D echo you identify the various leaflets. Many times you may not see a significant TR, or you see a TR, you feel that this is the leaflet which is causing it, but when you try to open it in all the views, you can see a different cause for it. The best to identify all the three leaflets is, of course, 3D echo you see. And if you are well versed with the 3D echo, this is the mitral valve apparatus, and this is the septal leaflet, this is the anterior leaflet, and this is the posterior leaflet, and this small one is the septal leaflet, this is the aorta. So this is how it looks in the three-dimensional echo if you have taken a full volume. And this can clearly tell you how much is the annular dilatation, how much is the leaflet prolapse, or any other structural abnormality which you are getting there. Now these are the echo parameters. I'll not go into the details. We all know them, how to identify the mild, moderate, and severe. Now, as I said, after this anatomy, let us go into why we are bothered about this tricuspid registration thing. It's not an innocuous thing. Of course, a lot number of population, as they grow older, you start getting a TR in some of these patients. In US, it has been seen that almost 1.6 million people have almost moderate to severe TR. Whereas out of this 16 lakh people, only 8,000 TV operations were performed. And majority of these prevalent TR are not more than mild TR, and they can be ignored significantly. But moderate to severe usually are pathological, and they are associated with poor prognosis. And most of the time, 90% of this moderate to severe TR are functional TR due to annular dilatation because of some other issue which is in the other part, like the left ventricular disease, or due to pulmonary hypertension or something like this. And acquired primary TR can be due to endocarditis, that means due to primarily cause of the valve itself, the tricuspid structure itself, due to endocarditis or rheumatic disease or carcinoid or foil leaflet, or due to, most important right now, is due to pacemaker lead implantation. This is something which has to be kept in mind, because if the patient has a moderate to severe TR after pacemaker lead implantation, he is definitely going to have significant morbidity and mortality in the future. This was a study, very nicely conducted study in the Olmsted city by Topolsky et al. And what they found that the left valvular diseases were the cause of 50% of TR. The pulmonary hypertension was cause of 23%, LV dysfunction 13%, congenital was 1.7%, and organic was here. So in this study, what they found is that they started prognosticating this patient, and they found that those who had at least moderate TR, they had a mean survival of around 28 years over 5 years. And it came down to 14 years over 10 years, and it was only 10% over 15 years, suggesting that the moment you have a significant moderate, say, or severe TR, your future outcome is going to be less and less. And those who had at least moderate isolated TR, where it was only because of some atrial fibrillation which giving rise to annular dilatation, even them also, without any other major heart disease or other issues, their observed survival was 50% at 5 years, and it was only 30% at 10 years and 25% at 15 years, suggesting the significant importance the TR was causing to the future outcome of this patient. And majority of these patients were put on medical management, and very few 2% were subjected to surgery. And what happened was, when they did surgery in this patient, almost 10 to 11% had a significant perioperative mortality. And this was found mainly in people who were in NOHA class 3 and 4. And that is where the importance of timing of surgery and timing of intervention is very important. So if you time your intervention or surgery when the patient is relatively better off, then you will be able to get a better outcome. So these are the various classification we use. The primary, when you have anatomical abnormality of TR; secondary, when the TR is secondary to some RADV dysfunction or due to RA remodeling because of increased RV pressure, or isolated when there is no other existing problem with the right ventricle, and mainly it is due to atrial fibrillation. So these are the causes of primary, secondary, and I will just not go into all the detail. The most common congenital is Epstein. They acquired, as you know, are mainly because of carcinoid or myxoma or some systemic diseases giving rise to hypertension. And this is where I wanted to highlight transvenous pacemaker or defibrillator induced TR. It is one of the most frequent acquired cause. And it is seen that those who never had TR in the beginning, almost 40% develop significant TR over a period of 1 to 1.5 years after lead insertion. And secondary TR is mainly because of RV dilatation and dysfunction due to some other cause. And we know 30 to 50% of patients with severe MR can have associated significant TR, or those 25% of severe AS also can have significant TR. And another important cause is significant pulmonary hypertension due to any other reason, either primary or pulmonary embolism. And isolated TR, as I said, it is because the presence of significant TR in absence of any concomitant pulmonary hypertension or coexisting left side disease. And so it is mainly seen in elderly people who have mainly atrial fibrillation giving rise to atrial dilatation and RA dilatation and giving rise to annular dilatation. So this is how, let us look at the prognosis, why it is important that we need to treat this TR patient. If it is a primary TR, the presence of significant TR, it causes an excess mortality of almost 4 per 5% yearly. And if it is a secondary TR, what we see, there was a small study by Hong et al. Of 117 patients who also had, some of them had severe LV dysfunction. The 1 year event-free survival in those who had a TR and who did not have TR was 30% who had no TR compared to 70% who had event-free survival was only 30% who had significant TR compared to 70% who did not have TR. Now, this was another interesting study of 1400 patients who had LV dysfunction, and what they found that the survival gradually decreased with increasing grade of TR over a period of 1 and 3 years. Those who did not have TR, their survival was 73% and 54% over 1 or 3 years compared to 65 to 42. And when they had severe TR, it was 58 and 49% only. This is how the Kaplan-Meier curve looks like. All cases of TR, if you see, this is the survival with severe TR. This middle one is the moderate TR, and this is with mild TR. Suppose we have taken a patient for TAVR. That is what we are doing now. If the TAVR patient has a TR also, if it is mild and moderate, which is the red and green, the outcome is this. But the moment he has moderate or severe, you can see the cumulative all-cause mortality goes up and up over a period of 12 months in this patient. Now, this last one is isolated TR. Again, isolated TR, if you have significant TR, the outcome is much, much worse compared to those who had mild or mild TR. Now, this is a patient who had got ischemic heart disease, and this is again patient who had got mitral valve disease. So you can see as the severity of TR goes up from none to mild to severe, the mortality or cumulative survival goes down. Same thing with patient who had got MR. And when we do surgery in these patients, because that is what used to be done earlier, isolated tricuspid valve surgery also had high operative mortality, almost more than 10%. And the timing and outcome of TV surgery will also depend on the presence of significant coexisting left-sided disease. So in primary TR, the level of recommendation or performing TV surgery as per current guidelines depends on various criteria, like whether he has severe TR or non-severe TR, what is the symptomatic status, or what is the progression of RV dysfunction. But in secondary TR, which is generally due to other associated disease, the recommendation is you should intervene when the severe TR is independent of symptom status, and if the tricuspid annular dilatation is more than 40. Normally it is 10 to 12, but if the moment it goes more than 40, whether he is symptomatic or non-symptomatic, you should still intervene in this subset of patient. So this is the European Society guideline recent for managing TR. If the patient had need for left-sided valve surgery, then you have to check what is the level of TR. It is mild to moderate. And if there is a significant tricuspid annular dilatation, then yes, definitely you have to do it. And if there is no significant dilatation, then you don't do it. And in patient who had no need for left-sided surgery, and if he has got a secondary TR in the absence of severe RV or LV dysfunction and of severe pulmonary hypertension, if it is present and the patient is symptomatic, then he has to go for repair. And if there is no such thing, then you can still continue with medical management. Something similar is also there in ACC-HA guideline. So friends, in concluding, tricuspid valve is no more a forgotten valve. The development of TR, whether it is primary, secondary, or isolated, has a negative prognostic implication. So we need to give due importance to this thing. And timely intervention can help improve outcome of these patients. So we should not wait for the patient to go into extreme stage of RV dysfunction or right heart failure before we intervene. And understanding of anatomy can help us design safe and effective therapy. Thank you very much.
Thank you, Dr. Bharat, for a very, very elaborate, talk, particularly the anatomy of the tricuspid valve. And I think it will be very important for all of us to understand the real anatomy in 3 dimensions to do some valve therapies, transcatheter. I feel in India, one of the reasons of tricuspid regurgitation functional is perhaps we don't advise surgery or intervention to our valve patients early. Partly it is our mistake, partly it is the patients also. So if we delay, if we can treat these patients before significant TR develops, I think we can prevent it. Actually, we should think about preventing tricuspid regurgitation rather than treating it. So I think in the interest of time, we can go to the last presentation by Dr. Santos. He is going to show some interesting cases. So we are not going to leave him to enjoy his Sunday before he shows some interesting cases to us. Dr. Santos.
Thank you so much. I am enjoying anyway. Thank you so much.
Thank you.
So since in my prior talk, I wanted to highlight the importance of the imaging in the planification, I'm going to show a particular case in this regard. I already presented this technology. This is the ideal computed tomography for these patients. We have to acquire the images with the CT in a very early stage when we just administer the contrast through the vein. And normally, since there is a severe tricuspid regurgitation, the contrast is pushed towards the superior and inferior vena cava, which means that normally we can see both of them very well. But there might be some exceptions. So it's important to acquire an early phase, the contrast, but also in the pulmonary phase, because sometimes we see better the inferior vena cava. Normally, we will administer the contrast from the superior extremities, not from the legs. This is why the inferior vena cava, which is the most challenging one for the implantation, sometimes cannot be seen so well. If we have a very nice CT, we can do these kind of reconstructions that are very beautiful, but sometimes we face cases like this. In this one, we have the contrast coming from the superior limb. So the superior vena cava is very well contrast on the atrium, but we cannot see any contrast in the inferior vena cava. The first thing that we have to think is that maybe the tricuspid regurgitation is not so severe. So we have to confirm that, because if there is a severe tricuspid regurgitation, there should be contrast to the inferior vena cava. But there is one more reason that might explain this, and it's a very prominent Eustachian valve. If there is a very prominent Eustachian valve, then it can preclude the contrast from going from the superior vena cava to the inferior vena cava. There is one potential solution, that is giving contrast through the vein in the inferior limb, but also we can just assess the inferior vena cava with echo images. Here you can see that really we have to measure with poor quality images for inferior vena cava in this case. And we are really not able to understand perfectly where it is. You can see here, we don't see the limits. And this is important because it's how we choose the sizing. But here, more or less, we can see also the Eustachian valve that is limiting the pass of contrast. Okay, and now I'm going to show the case. So I will remove the sound. These are my colleagues in the team. And let's go to the case. So initial angio is very important. Here we can see the bifurcation with the innominate vein. And this is the angio in the inferior vena cava that in this case, we can see is really, really challenging because there is a huge tortuosity of the inferior vena cava. So we don't have an unprepared CT and we have a challenging anatomy by angio, which is why I wanted to show this case. Also, the patient has a pacemaker, as you can see, which was discussed before. And we can see that there is a significant tricuspid regurgitation and all the flow is against the Eustachian valve. This is where the contrast is not going down. This is an extremely prominent Eustachian valve. It's quite uncommon to find a valve like this, but you can see that this is the explanation why we cannot see contrast. Okay, we can see the pacemaker lead going through the tricuspid valve as well. And in fact, this kind of Eustachian valves, more than a problem for the procedure, are a very good help because the risk for inferior vena cava is going too high when the valve is released, but somehow the Eustachian valve acts as a stopper for the valve, so it precludes it from going up. Another important factor that we can see here is the pressure. And sorry. And here we can see by transthoracic echo the aspect of the inferior vena cava. We are all used to see a subcostal view by echo, and normally we see a straight vein, but in this case it's like a varicose vein with a huge tortuosity. So this procedure, I like it because we have transesophageal echo, but as you can see by transthoracic echo, the procedure could be also very well guided with no problem. So we can see the Eustachian valve also by the transthoracic echo, and we have our pigtail in the inferior vena cava that we can see here. We measured 28 millimeters here. So we took several measures at different levels because, as you remember, the CT was not useful for measuring the inferior vena cava. And one important thing also of this valve is that it's already pre-mounted, it's crimped. You don't need someone in your team that is trained to know how to crimp this valve. The valve is crimped. You just need to rehydrate the leaflets by flushing the delivery system during 4 minutes. This is probably a concept that it's going to extend to the CAVI devices as well. Now you need someone who knows how to crimp the balloon expandable ones, the self-expandable ones, but if TAVI is already pre-crimped, like the coronary stents, then you can use it immediately from the self to the patient. It's important to avoid any kind of step that the nose cone is not separated from the delivery catheter to avoid damaging the proglides or the access. And here you can see how we enter. Normally we pre-close with 2 proglides in these cases. So during the delivery, you see the pacemaker lead. In this case, we have been careful, but still it was all around the vein. So we have to be very careful while advancing the valve to avoid tension over the lead that might move it from the correct place. And as you can see, the vein is not very straight, but the deployment is nice. At this point, we can remove our pigtail because we have seen the innominate vein. We have the lead as a marker of the innominate vein because it's coming from there. So now the valve is deployed, and you can see that the pacemaker lead remains there, but there is no problem with that. The valve is normally functioning. And now we start with the challenging one, with the inferior vena cava one. You can see also the TE images in your up left image. So here the leaflets are already working, as you can see in the TE. We are the hepatic side, we can see with contrast that we are still a little bit high. But remember that we have the Eustachian valve right here, stopping the valve from moving up. The images are a bit accelerated, so the deployment must be much slower than this. And we have to release each of the 3 hooks one by one. Remember that the vein was very tortuous, but once we are deploying the valve, this vein is going to straighten, which means that we are distorting the anatomy completely, and the references that we had before are not valid. So the valve is almost deployed. We remove the pigtail. See that the vein is doing the small bending here. And finally, the valve is deployed with no movement at all when it's fully deployed, although it starts moving with the breathing of the patient once it's completely deployed. And we can see by TE how the valve is functioning. We did an angio. We can see that there is no backflow. And we also can see how well the Eustachian valve is stopping our valve here. So they are both valves together. And this was the challenging case that I wanted to show you. So normally the inferior vena cava is a very straight vein, but you can find tortuosities that usually are associated with other abnormalities, as a prominent Eustachian valve, prominent Chiari net, things like that. Thank you very much. Any questions?
So, Dr. Santos, if they have to embolize, they embolize during the procedure, or they can embolize later on also, after a couple of days or a couple of weeks. That kind of thing has been observed or not?
So embolization is very rare. That's the first message. The only reason why it can happen is when there is a very rapid deployment, because this is a self-expandable valve, very strong. And if you don't give time to the veins to adapt to the valve, then they can go down. And normally the cases that have been described with embolization have occurred acutely. To the best of my knowledge, there is only one case that it was detected 24 hours later, but I think probably it happened immediately after the deployment of the superior vena cava prosthesis. But we did not see it, and in the next day echocardiography then found that the superior vena cava has moved down.
Right. If there are any questions from the other panel members or the other faculty members, they are welcome to ask.
I have one question.
Yeah, please.
Dr. Santos, what is the cutoff pulmonary artery pressure above which, meaning this type of tricuspid valve, trick valve is not suitable? I mean, is there any cutoff limit?
So for the study, it was 65 millimeters of mercury. And the reason for that is that since normally in these patients, the right ventricle is not fully functional, normally they have mild or moderate dysfunction, and we are going to remove all the backflow to the veins, then there is no escape for that ventricle. So if there is a very high pulmonary pressure, you might face right ventricular acute failure. So I think if the patient has more than 65 millimeters of mercury, the procedure should be avoided. Of course, this pressure has to be measured during a stable phase, because I have screened several patients that were admitted due to right heart failure, acute right heart failure, And then the right heart catheterization was performed. That's not the ideal moment. The ideal moment is when the patient is at home in the stable situation. And that's the pulmonary pressure that we have to take into consideration.
Another thing, Dr. Santos, I want to know is it also important to understand the RB function? So is it that severe RB dysfunction is a contraindication, or you want to elaborate on that issue?
So this is probably the most important thing, not only for this therapy, but for all the percutaneous therapies that we are discussing in this webinar. Severe right ventricular dysfunction cannot only be assessed with the TAPSE. So if the TAPSE is very, very low, below 9 millimeters, probably this is severe dysfunction, but we have other parameters. We have the working index based on the right heart catheterization, which is very useful. And in many patients, we can perform also MRI, which can be very useful to understand if the ejection fraction is below 35%. So ejection fraction below 35%, TAPSE below 9, or a working index below 1.5 should exclude the patients for any percutaneous therapy, probably.
They won't do well anyway, because the disease is pretty well advanced. Yeah. Anybody else? Any question, please?
Dr. Santos, there was a question. Yes, sir, please continue.
Yeah, so one question is, how long does it take for the right-sided heart failure to settle down once you have put the valve? Means how usually these patients present with generalized edema, hypoproteinemia and all that. How is the natural history after you have implanted the valve?
So the benefit we are seeing at the 3-month follow-up, there is in the series of patients that I have presented, the mean loss of weight was of 3.5 kilos at 3-month follow-up. But the initial month, the initial 2, 3, 4 weeks, we cannot see so clearly the improvement of the patient. So this is progressive, as well as the reduction in the size of the right chambers. The control CT for the study was performed also at 3 months of follow-up, and there we could identify the adequate remodeling of the right chambers, but not in the echo at 1 month follow-up. So probably from 3 months ahead, we can see this positive impact.
In nature, you do not have any valve in coming down from the superior vena cava. So once you put a valve there, is there any flow changes or anything stasis which can increase thrombogenicity of the veins or something like that? Any flow related changes that takes place after this valve?
So I think these patients need to be maintained with oral anticoagulation lifelong. Normally they have another indication for that anticoagulation. We have not seen any leaflet thrombosis, but as I saw before, there were in 2 cases small thrombi adhered to the stent. And in these patients, the range of anticoagulation has not been adequate all the time. So yes, there is a risk for valve thrombosis, but until now, it has not been described affecting the leaflets.
So, Dr. Santos, once you have implanted both the superior and inferior cable valves, so you don't see at all any flow from the right atrium to the SVC or IVC, or you see mild flow or no flow at all?
If the valves are correctly implanted, that there is no leak, there is no flow at all.
And if there is some paravalvular leak as well, some concern?
There has been some cases. I think in the trial there were 2 cases with paravalvular leak in the inferior vena cava because it was implanted too high. So there was mild paravalvular leak. Actually, these patients, one of them is from my center, improved a lot. So even with a mild leak, improvement was very clear for that patient. But if that leak is more important, probably the therapy is not effective.
In these valves, once you have implanted these valves, as you told, the pacemaker leads, there is no malfunction. Pacemaker leads continue to function well. But I think one issue will be if you have to extract these leads, then which is sitting just outside the valve, it will be difficult because you cannot extract these pacing leads if they are infected. That is one problem.
Yeah, that's a risk. Clearly, that's a risk.
Yeah, I think extraction won't be possible after the valve implantation, but usually so far the experience has been the leads don't malfunction. You can put a new lead through the valve, as he has already explained, but that will cause some degree of valve, regurgitation. So I think all those things we have to learn with more and more follow-up and more cases. I guess the time is pretty, I think we are beyond the time already. And if the relisys people allow me, I think we can close this webinar, or you have some other?
Yes, sir. Sir, before that, Dr. Santos, there has been one question which I would request you to take up. Should the contrast CT be done with lower and upper extremity junctions?
So first, I'd like to comment something on the endocarditis risk. For that risk, if the patient has a prior endocarditis, I would avoid implanting a valve trapping a lead. That's my advice. But if it happens, you might even try to remove it with one of those extractors of leads, even if it's trapped. Anyway, it's not an ideal scenario. And regarding the contrast, it's not necessary to administer contrast from the inferior limb. Normally with the TR, the contrast is pushed towards the inferior vena cava. I just saw a very specific case with a very prominent Eustachian valve with it did not work. So, but this case is rare. It's the only case we have had that we did not have a good contrastation of the inferior vena cava.
Okay, thank you. And then there was another question: how do you do angiograms pre-procedure?
So we do it always during the procedure, not before, not during the right heart cath. And we do just one angio in the superior vena cava to identify exactly where is the nominate vein. And then in the inferior vena cava, we position a pigtail catheter in the hepatic veins and inject contrast as many times as necessary to identify how high, how deep in the atrium we are with the valve. We have to be restricted because most of these patients have some degree of renal failure, but it's necessary for the implantation.
Thank you, Dr. Santos.
Thank you so much.
So I think with this, we conclude the webinar. I would thank Dr. Santos and other faculty who have immensely contributed to this webinar. And I think it is exciting. This will certainly stimulate interventional cardiologists in India to adopt these therapies. Thanks again, relisys, to bring this. Hopefully, they will bring this technology soon to India. Thank you very much, all of you.
Yeah, currently the valves are available for use, sir. Thank you. And before we conclude, I would request my colleague, Mr. Kennedy, to give a vote of thanks.
On behalf of Relisys Medical Devices, I take the opportunity to thank all of you. Our chairperson, Dr. Claire, for guiding us through this meeting. Our moderators, Dr. Jagtap and Dr. Sigdar. Our speakers and presenters, Dr. Girish, Dr. Santos, Dr. Viveka, Dr. Purohit, and all of you delegates and attendees. Thank you for being part of this initiative of Relisys Medical Devices. We look forward to interacting with you in the near future. Thank you once again and have a good day, all of you.
Thank you.